So here I'm going to discuss the COVID-19 causing virus, which is SARS-CoV-2. SARS is sudden acute respiratory syndrome. It's a coronavirus, and it's given the subtype 2. So the COV is coronavirus. COVID-19 for the year 2019 became a pandemic, and let's just discuss a little bit of this virus. So now, just very briefly, the virus has these spike proteins, and the spike proteins confer the tropism of the virus because it's going to bind to cells that express ACE2 receptors. So this is tropism. Now, the virus is going to get into the cells. It's considered a beta or B coronavirus, and like all coronaviruses, it has an envelope protein. It also has that famous spike, of course. It has a hemagglutinin, which is found on other viruses like parainfluenza virus and influenza virus. It is an RNA virus, and it will enter the cell and will cause infections. Now, there are some other pathogenic human coronaviruses. We had in 2003 emergence of SARS-1. It's now called SARS-1. It wasn't very transmissible. There were only about 8,000 cases, and it had about an 11% fatality rate. So the transmission in this virus was very low. MERS, on the other hand, had a low transmission rate as well, except for it had a higher fatality rate. MERS stands for Middle Eastern Respiratory Syndrome. And so this came from camels, for example. The outbreak was caused by interactions of humans and camels as one of the sources. And this had a 34% fatality rate. And now we have SARS-CoV-2, which is very transmissible. So that's here. It's highly transmissible, but its fatality rate based on its cases is much lower. However, because it infects so many people, there are a lot more deaths associated with SARS-CoV-2. And there's always a question, when's the next coronavirus going to happen? So you can see that it's happened almost every 8 years. So is this going to be a new cycle with these particular strain of virus? Now, how does it get in? So again, ACE receptor. It starts as a respiratory infection. So this is going to be found on your goblet cells of your nose, as well as ciliated cells in your upper respiratory tract. In your lungs, ACE receptors are on your type 2 pneumonocytes. Now, how does it get systemic? You're hearing a lot about people getting infected or the virus being found in other tissues. So in the gut, the enterocytes are going to express ACE2 receptor. Your endothelial cells lining your blood vessels do. In your heart, your cardiac myocytes, and in the central nervous system, olfactory neurons can express ACE2 receptors. So just like any virus, your immune system will respond to it. Your immune system will detect that there's a virus. RNA will trigger the toll-like receptors, and you'll get that prodrome, the initial inflammatory response, very general flu-like symptoms. And then you're going to get activation of your acquired response, your T cells. So you're going to get your T cells activated. They're going to become effectors. And then your effectors are going to go through your body, search for any SARS infected cell, and kill that infected cell. And that's when you start to get specific symptoms of the actual infection. So the virus is obviously replicating in your lungs, so you start to get respiratory symptoms. So it was initial flu-like symptoms, which is common to most viral infections, and it shifts to a more specific SARS-CoV-2 symptoms involving the respiratory tract. So what's going on in some patients? Why do some patients have more severe infections than others? And we're still learning about this, but some things that have happened with respect to this infection that is kind of curious. Some individuals, when you take a lymph node biopsy, they show a lack of germinal center formation. And in these individuals, you typically find low antibody production, no isotype switching, and a low IgG response. And so germinal centers are important for generating those really good antibodies. So it's unclear why in some patients this does not occur. In some patients, there's also an overreaction of the innate immune response, and this leads to cytokine storms, the release of pro-inflammatory cytokines systemically, and this can lead to shock. And so in general, basic definitions are infection. So with an infection, you have basically the body is being invaded and the agent is causing disease. And an inflammation, that's basically the body's response to this infection and fighting things that it sees it as being foreign and harmful. And it does this by initially releasing chemicals to help the immune response communicate and alert them that there is an immune response or there is an infection that's ongoing. And these cytokines are what are going to potentially cause the storm. It depends how many cells are activated, how much virus is present. All of that plays a role. And keep in mind that the purpose of the vaccine is to keep the virus number down. It's not to eliminate the potential for an infection, because that will always occur with a virus, but it's to eliminate that massive replication of the virus so you prevent things like the cytokine storm, shock, and dissemination to those other tissues we just talked about. So this is an example of the inflammatory storm. You can see the lungs on the left are from a normal individual, and the lungs on the right are taken from a person suffering from coronavirus. So you see a lot of inhibition in the lungs, which correlates with the difficulty of breathing. Some people with the most severe cases of coronavirus that need to go on ventilators. So within the United States, the case fatality rate is going to be highest in people who are over the age of 85. Within the group, though, that's over the age of 65, they are harboring most of the fatality with respect to this virus. And those under the age of 65 typically will have less death, and most of those deaths are associated with comorbidities. Now, detection of infected or exposed, so again, we're looking at days onset of symptoms. And so you're looking at antibodies detected by ELISA. So this is just giving you whether the patient has antibodies, whether the body has seen the virus. And then you're looking at viral RNA. Is the virus actually there? Can you detect it? Is it replicating? And so early on in the infection, you can see that detection of the viral RNA is going to be the best way to detect whether a person is actively infected. But then after the infection falls off, you're looking now at the response. So did the patient have the infection? Can you detect those IgEs or IgGs in their blood? And this indicates that they did have seroconversion, which for SARS means they were infected. Now, why would you say that they're not infected now? And that's simply because the antibodies to detect, this is the antibodies available to detect, become available as you're clearing the virus, as the virus is going away. So the period before the virus is going away, you can't detect these antibodies very well. And so typically seroconversion in the case of SARS-CoV-2 is a convalescent measurement. It's not an active infection measurement. Now, with respect to drugs and treatment, there is remdesivir, which is one of those nucleotide analogs. This remdesivir is also used for other types of infections. Recently, Merck came out with a new promising drug that they say may be similar to Tamiflu, but this timing has to be essential because Tamiflu has to be given within a period of time or else it is not effective. And you can think about the life cycle of a virus and why that makes sense. Tamiflu is going to prevent the replication of it's going to prevent the assembly of the virus. It's going to target neuraminidase. And so if you have too much virus already around, it's infecting other cells, it quickly can get out of hand. So you want those treatments very early. Drug treatments to target the cytokine storm are going to be those anti-inflammatories, cyclosporins, other drugs that have been used to treat things like sepsis in the past are going to be used to help target cytokine storm and prevent shock. Now, just a quick look at the vaccine pipeline. You can follow this at the New York Times. So we have different phases of development of a vaccine. Phase 1 is basically they're trying to figure out, is this even safe and what dose is needed? The phase 2 is a safety trial, so it's a bigger safety trial, no efficacy. Phase 3 is where you get to your efficacy test. Currently within the pipeline, we have 13 authorized vaccines that are either in early or limited use, 8 that have been approved for full use, and 6 that have been fully abandoned after clinical trials. So just very quickly, vaccine approaches with the SARS-CoV-2. Most of the vaccines that we've been seeing, especially in the United States, are what I would call alternative vaccines. They are going to be genetic vaccines such as Moderna, Pfizer, inactivated viral vectors, which is not the same as an inactivated vaccine. A vector is a carrier of a vaccine. A true inactivated live virus would be a live attenuated SARS virus, which is shown over here. And these are being developed in China as well as India. But the one we have for Johnson & Johnson is a vectored vaccine, which is an alternative vaccine approach. And then, of course, there are some that are trying to do the proteins, which are the weakest vaccines, and they're adding adjuvants to try to enhance the immune response to these very weak vaccines. So then down and next. So we know what happened in the past. We know what we've all been through with this pandemic. So what is going on right now? Well, we know that SARS can be transmitted before symptoms. We know that SARS can involve multiple organs influence during the infection process. There are currently antibody treatments and some antivirals for severe cases. We have had effective protection with social distancing, but how long do we have to do this for? And what about the unvaccinated versus the vaccinated? It is very well known that the vaccinations work against all the variants now, so we have multiple variants, but one seropositive. So all of our antibodies work against multiple variants of the virus. Currently, the unvaccinated take up about 98.6% of all COVID-19 hospital-admitted cases. Those are those severe cases. They're now coming mostly from unvaccinated. Vaccinated people can still get infected. Vaccines do not prevent infection. They never have. However, what you're preventing is disease, and you're preventing the possibility of transmission. Now, we have a lot of people who have comorbidities. Those are the susceptible people. And even if they get vaccinated, the vaccine might not work as well in those individuals. That's why it's very important for the general healthy population to get vaccinated to protect those that, even if they do get vaccinated, are still at risk for disease. So there's a lot of work that needs to be done, especially with public health and especially in trust of the population with respect to vaccinations.